In this module, we're going to review the mechanisms responsible for muscle injury. We'll also discuss delayed onset muscle soreness, also known as DOMS, and we'll look at if there's anything we can do to prevent muscle injury as well as DOMS. So we'll look at contraction-induced muscle injury, so the shortening of the sarcomeres. We'll look at the different phases of injury, as well as preventative measures for skeletal muscle injury. I highly recommend that you go back to the lecture on muscle structure and function and review the anatomical components of skeletal muscle. There are essentially 4 stages of exercise-induced muscular injury. The initial phase is where we have a damaged cell that breaks down, so the muscle cell degrades. During the autogenetic phase is where the satellite cells come in to replace the muscle fibers that are damaged. So we have these new fibers that are going to be formed out of the satellite cells. During the phagocytic phase, we have macrophages that come in and remove all of the debris that degraded so that we can clear the way for new muscle cells. During the regenerative phase is where we have satellite cells divide and fuse together so that the nuclei congregate in the center of the new fiber to create a new muscle fiber. The new fiber with the nuclei at the periphery. This is the beginning of a new muscle fiber. In the diagram on the right-hand side, we have a skeletal muscle that has been injured by repeated eccentric contractions. Damaged muscle fibers have been invaded by macrophages, that's what the arrows are pointing to, which phagocytize cellular debris to enable fiber regeneration to occur. So the macrophages are essentially coming in and just removing all of that garbage that we don't need anymore so we can make room for the new fibers. Let's take a moment to review the cytoskeleton of a muscle fiber. Remember that these are the structural proteins that provide an infrastructure to stabilize the contractile protein elements. Without these elements in place, this would all fall apart. If you recall, we talked about titin, which holds the myosin filaments to the Z-lines so that we can have organization within the sarcomeres. The support structures outside of the cell, like the endomysium, are linked to the intracellular infrastructure through a protein called integrin. With skeletal muscle fiber damage, particularly with eccentric contractions, the initial damage to the skeletal muscle fiber will be located at the Z-line, resulting in something we call Z-line streaming, or a splitting of the structure. That's what you're seeing at the bottom half of this diagram. This results in a loss of transverse register of sarcomeres and a decline in force production capability. So in other words, the alignment of the sarcomeres is now off, and therefore force production is going to be affected because the myosin and actin filaments are no longer in alignment and in an optimal configuration to produce force. With skeletal muscle injury, most of the damage is going to be associated with the eccentric phase of the contraction versus an isometric or concentric contraction. This damage is as a result of muscle strain, so the relationship between the actin and myosin filaments, more so than a stress, that is, the amount of force that's produced per given unit of area. We're going to end up with more skeletal muscle damage when the activity is performed at longer muscle lengths. So the more that those sarcomeres are lengthened, the more likely we're going to have muscle damage. In severe muscle injury, this might result in the destruction of entire skeletal muscle fibers. There are basically 2 distinct phases of skeletal muscle injury. Phase 1 of skeletal muscle injury is basically mechanical. That's where we have structural damage to the sarcolemmal membrane or perhaps even the cytoskeleton of the sarcomere. In phase 2 of skeletal muscle injury, that's more related to the inflammatory response of the immune system to the injured area. This tends to peak at 2 to 3 days post-injury. We can visualize these 2 phases on this graph. On the y-axis, we have the percentage of maximum force, and on the x-axis, we have the days post-injury. The muscle is mechanically injured initially, so that's the phase 1. That's going to disrupt all the contractile elements. That initial decline in force is related to fatigue plus cellular breakdown. Within 2 or 3 days, further damage is observed and is associated with the inflammatory processes. The repair process, however, is going to take days or even weeks, depending upon how severe the skeletal muscle damage is. So let's take a look at the proposed mechanism for delayed onset muscle soreness. By performing strenuous skeletal muscle contractions and emphasizing the eccentric contraction, that's going to result in structural skeletal muscle damage. That will disrupt the alignment of the sarcomeres. Therefore, that's going to lead to reduced force production. These eccentric skeletal muscle contractions lead to things like the sarcolemmal membrane and the sarcoplasmic reticulum being damaged. And let's not forget about the cytoskeleton. That disruption of the sarcomeres is as a result of breakdown in the integrin as well as the titin that we talked about. When the sarcoplasmic reticulum is damaged, that allows calcium to leak out. And that calcium then is going to accumulate in the mitochondria. This will inhibit ATP production. The accumulation of calcium also activates proteases. These are enzymes that are designed to degrade proteins. So the contractile elements, actin and myosin, the cytoskeleton proteins, titin, integrin, all of those can be degraded by these proteases. That, of course, is going to result in structural damage and reduce force production. The sarcolemmal membrane damage, as well as the sarcoplasmic reticulum damage, in combination with proteolysis, that is protein degradation within the muscle, is going to stimulate the inflammatory process. We're going to get the release of prostaglandins and histamines into that area, which is going to make us feel pretty bad. We also get the generation of free radicals. Free radicals are these bad substances that go in and cause further damage by stealing electrons from structures in the surrounding area. The accumulation of histamines and the swelling or edema that surrounds the muscle fibers are going to stimulate nerve endings, which then is going to, of course, stimulate pain. So are there any preventative measures that we can take against skeletal muscle injury? And what are the treatment modalities for skeletal muscle injury? During phase 1, it appears that there is a prophylactic effect of a single bout of eccentric exercise that lasts approximately 9 to 10 weeks. This is known as the repeated bout effect or the repeated bout theory. There are several purported mechanisms for the repeated bout effect. The first of which is the neural theory. This theory suggests that the muscle fibers that are activated are initially going to be mostly type 2 fibers. With continued exercise training, there seems to be better motor unit recruitment. In other words, there's a distribution of the stress over a larger number of muscle fibers that helps to minimize the amount of damage that we get. The intramuscular connective tissue theory suggests that we increase the amount of connective tissue in the muscle, which protects us from further damage. There is evidence in the scientific literature that does support this theory. We know that an increase in intramuscular connective tissue is actually associated with a decrease in injury, and a decrease in tensile strength is actually going to increase our risk for injury. And lastly, the cellular theory suggests that there are new proteins that are made that actually protect the skeletal muscle fibers against damage. These include stress proteins and new cytoskeleton proteins. Could this be related to the addition of new sarcomeres? Muscle physiologists are still working in this area to determine more specifics related to this theory. What about during phase 2? Do we have any anti-inflammatories that we could use? Well, it turns out bromelain, which is a phytochemical that's extracted from pineapple, may be able to attenuate secondary injury. That is the inflammatory part of this whole process. It's fairly common for athletes to be given ibuprofen, which is an NSAID, that is a non-steroidal anti-inflammatory drug, so that they can reduce the amount of pain that they might experience. However, at the current moment, the scientific literature is really inconclusive about this. Some studies say yes, some studies say no. At best, ibuprofen is really only reducing soreness about 15%. An athlete should consider the risk-benefit ratio when it comes to ibuprofen. There is a higher risk for endotoxemia. That's when the bacteria leave the gastrointestinal tract and enter the bloodstream. This causes higher oxidative stress, and therefore increases C-reactive protein and cytokines. So this may further exacerbate the problem. What about antioxidants? Since free radicals are generated during this process, can I use antioxidants to ameliorate the inflammatory response? This really seems dependent upon the nature of the activity. When we look at vitamins A, C, and E, it's very specific to the type of exercise that we're doing. For prolonged exercise, where we have an elevation in oxygen uptake, we get a lot of free radicals produced from the mitochondria. These are oxygen radicals. The antioxidants seem to be effective in reducing damage from this kind of work. So vitamins A, C, and E seem to protect us against the oxygen-free radicals that are generated with this kind of exercise. However, with forceful contractions, the oxygen radicals are actually coming from activated white blood cells, or leukocytes. And in this case, it doesn't seem that antioxidants seem to be very effective. So the use of antioxidants really is very specific to the type of activity that the person is doing. In summary, when it comes to skeletal muscle injury, we want to make sure we're taking advantage of training specificity so that we can prevent future injuries from occurring. That is, the athlete should train in the exact pattern of movement that they're going to be using in competition. When we look at eccentric versus concentric training, there's going to be a greater hypertrophic response with eccentric contractions. However, that comes at a price. We increase the risk of injury with eccentric contractions, which may then result in the degeneration-regeneration cycles that we talked about earlier and the satellite cell activation. This leads to the question of how many degeneration-regeneration cycles does a skeletal muscle have? So the concern is that exercise-induced skeletal muscle injury will result in the decreased ability of the skeletal muscle to repair itself. In fact, in the scientific literature, there's more and more evidence that supports this intimation. This might relate to a declining population of satellite cells because we keep using them up. Over time, as the muscle is repetitively injured, it's replaced with fibrous connective tissue. Another concern is that skeletal muscle injury is associated with a large efflux of protein into the bloodstream. That can actually lead to kidney and liver failure, and in some cases, it can actually be fatal for a person. Scientists are also concerned about the alterations of biomechanics to the lower extremities. Repetitive skeletal muscle tissue damage could lead to muscle weakness in the lower extremities, which then alters the way that someone runs, for example, which then could increase the risk for things like stress fractures or even ligament or tendon damage. One last concern is that of the senior population becoming more and more active. They are actually more susceptible to exercise-induced skeletal muscle injury and also have a diminished capacity to repair that tissue. In fact, in some of the research studies, skeletal muscle tissue damage was found up to 6 months after a single bout of exercise. As exercise physiologists, it's imperative that we analyze the risk-to-benefit ratio, especially given everything that we just talked about with skeletal muscle injury. We want to make sure we're customizing and individualizing training programs to accommodate the needs of that specific individual. The needs of an athlete, of course, are going to be different from someone who's a senior or someone just looking for health-related benefits. So we can take advantage of our ACSM guidelines and as well as our NASM guidelines and our strength and conditioning principles to accommodate training programs to fit the needs of that particular population.